Hello everybody, I am Dr. Amit Gupta. Today we will talk about ECG Basics Part 2. If you did not watch ECG Basics Part 1, then first watch Part 1 by click the link given below. In this video, we will try to interpret different kinds of rhythm using ECG. So objectives of this video is to recognize the normal rhythm of heart like normal sinus rhythm, to recognize the 13 most common rhythm disturbances, to recognize an acute myocardial infarction on a 12 lead ECG. We will try to find out different types of rhythms using ECG like sinus rhythms, premature beats, supraventricular arrhythmias, ventricular arrhythmias, AV junctional blocks. What is this rhythm? First, we will calculate the rate by calculating the large boxes between two QRS complexes. So it comes out to be 30 beats per minute. Is it regular? Yes, this is regular. P waves normal? These are absolutely normal. What is the PR interval? It's about 3 boxes, small boxes. So it's 0.12 second. What is the QRS duration in this? It's around 0.1 second. So what is your interpretation? It's a sinus bradycardia. Why it is bradycardia? Because deviation from normal sinus rhythm means in this rate is less than 60 beats per minute. Why it is sinus? Because SA node is depolarizing slower than normal. It means impulse is conducted normally. We can see there is normal PR interval and QRS interval. It means impulse is originating from SA node. So this is sinus bradycardia. In this strip, the rate is about 130 beats per minute. Yes, it is regular. P waves are normal. PR interval is normal. QRS duration is also normal. So our interpretation is this is a sinus rhythm and tachycardia is present. So it's sinus tachycardia. In this, SA node is depolarizing faster than normal. Impulse is conducted normally. So it's sinus tachycardia. Remember one thing, sinus tachycardia is a response to physical or psychological stress. It's not a primary arrhythmia. Now we will talk about premature beats, premature atrial contractions and premature ventricular contraction. In this strip, first we will find a rate. So it comes out to be 70 beats per minute. Is it regular? No, it is occasionally irregular. What about P waves? We can see out of these 7 P waves, 2 are with different contour. These two. What is the PR interval? It's about normal except these 2 waves. QRS duration? Yes, it is normal in all leads. So interpretation, this is normal sinus rhythm with premature atrial contraction. These ectopic beats originate in the atria but not in the SA node. Therefore, the contour of P wave, PR interval and the timing are different than a normally generated pulse from the SA node. When an impulse originates anywhere in the atria like SA node, atrial cells, AV node, bundle of his and is conducted to the ventricles normally, then QRS will be narrow. In this strip, we can see rate is about 60 beats per minute. Yes, it is occasionally irregular. What about P waves? It is present for every QRS complex except the 7th one. PR interval, so it is normal 0.14 second. QRS duration, yes, it is normal for all the waves except this 7th one which is wide. What is interpretation now? It is sinus rhythm, yes, with 1 PVC. Ectopic beats originate in the ventricles, resulting in wide and bizarre QRS complex. When there are more than one premature beats and look alike, they are called uniform. When they look different, they are called multiform. What causes PVCs? One or more ventricular cells are depolarizing and the impulse are abnormally conducting through the ventricles. When an impulse originates in a ventricle and conduction through the ventricles will be inefficient and the QRS will be wide and bizarre. Supraventricular arrhythmias, atrial fibrillation, atrial flutter and paroxysmal supraventricular tachycardia. Now in this rhythm, rate is 100 beats per minute. Is it regular? No, it's irregularly irregular. What about P waves? There is no P waves. What about PR interval? So there is no PR interval. QRS duration? Yes, it is normal. So interpretation is it is atrial fibrillation. When there is no organized atrial depolarization, so there is no P waves. Means atrial activity is chaotic, resulting in a irregular rate. What about this rhythm? Rate is 70 beats per minute. Regularity, yes, it is regular. What about P waves? This is flutter waves. PR interval, none. QRS complex, it's normal. Interpretation is very simple, atrial flutter. There is no P waves, instead flutter waves are formed at a rate of 250 to 350 beats per minute. You can observe the sawtooth pattern. Only some impulses conducted through the AV node. Re-entrant pathway in the right atrium with every second, third or fourth impulse generating a QRS complex. Others are blocked in the AV node as a node repolarizes. In this strip, we can see the starting rate is 74 beats per minute, which suddenly converted into 148 beats per minute. What about regularity? It is regular in starting and again regular in the later stage of ECG. What about P waves? In starting, we can say clearly there is presence of P waves, but in later half there is no P waves. What about PR interval? Similarly, at starting normal PR interval and in later half of ECG there is no PR interval. What about QRS duration? It is absolutely normal throughout the ECG. So interpretation will be paroxysmal supraventricular tachycardia. The heart rate suddenly speeds up, often triggered by a PAC, which is not seen here, and the P waves are lost. There are several types of PSP, but all originate above the ventricle. That's why QRS complex is narrow in PSPT. Ventricular arrhythmias, ventricular tachycardia, and ventricular fibrillation. What about this? First, we will calculate the rate. It comes out to be 160 beats per minute. Then regularity, yes, it is regular. What about P wave? There is no P wave. PR interval, so none. What about QRS duration? Yes, it is wide. We can see there is more than 3 to 4 small boxes. Means QRS complex is wide. What is the interpretation? Ventricular tachycardia. Impulse is originating in the ventricles. That's why there is no P waves and the QRS complex is wide. There is a re-entrant pathway looping in a ventricle. This is the most common cause of ventricular tachycardia. Ventricular tachycardia can sometimes generate enough cardiac output to produce a pulse. At other times, there is no pulse. In this strip, we can see we cannot calculate the rate, regularity. This is totally irregularly irregular. There is no P waves, no PR interval. What about QRS duration? It is wide if we can recognize the QRS duration. So interpretation is ventricular fibrillation. The ventricular cells are excitable and depolarizing randomly. So there is rapid drop in the cardiac output and death can occur if not quickly reversed. To diagnose right ventricular hypertrophy in ECG, there should be tall R wave in V1 with R by S ratio should be more than 1 and deep S wave in lead V5 or V6. What about left ventricular hypertrophy? Compare these two ECG. We can see there is a high voltage complex in second ECG, means tall QRS complexes in V5 and V6. Why is left ventricular hypertrophy characterized by tall QRS complexes? As the heart muscle wall thickens, there is an increase in electrical forces moving through the myocardium, resulting in increased QRS voltage. What is the criteria to diagnose LVH using a 12-lead ECG? For example, the R wave in V5 or V6 plus the S wave in V1 or V2 should exceed 35 mm. However, for now, all you need to know is that the QRS voltage increases with LVH. Bundle branch blocks. This is a normal impulse conduction. SA node, AV node to bundle of his to bundle branches, then finally terminates in Purkinje fibers. So, depolarization of the bundle branches and Purkinje fibers are seen as a QRS complex on ECG. Therefore, a conduction block of the bundle branches would be a reflect as a change in QRS complex. With bundle branch blocks, you will see two changes on the ECG. Either QRS complex widens or the morphology of QRS complex should change. Why does the QRS complex widen? When the conduction pathway is blocked, it will take longer for the electrical signal to pass through the ventricles. QRS morphology is characteristic in right bundle branch block. The wide QRS complex assumes a unique, virtually diagnostic shape in leads overlying the right ventricle V1 and V2, and it is typically called rabbit ears. For left bundle branch block, the wide QRS complex assumes a characteristic change in shape in left oriented leads, broad and deep S waves. AV nodal blocks. First degree AV block, second degree AV block type 1, second degree AV block type 2, third degree AV block. In this rhythm strip, we can find rate is approximate 60 beats per minute. It is regular and P waves are normal. But about PR interval, we can see PR interval is 0.36 second. It means it is prolonged than normal. QRS complex is of normal duration. So interpretation is first degree AV block because it deviates from normal sinus rhythm by increase in PR interval, which is more than 0.2 second. Prolonged conduction delay in AV node or bundle of phase is the etiology of first degree AV block. What about this ECG? Rate is 50 beats per minute. It is regularly irregular. But about P waves? P waves are normal. But fourth P wave has no QRS. PR interval is gradually lengthened till the QRS complex is absent. QRS duration is normal, so interpretation is second degree AV block type 1. PR interval progressively lengthens, then the impulse is completely blocked. Means P wave will not be followed by QRS complex in second degree AV block type 1. Each successive atrial impulse encounters a longer and longer delay in AV node until one impulse fails to make it through the AV node. It is usually third or fourth impulse. Now the rhythm number 12, what is the rate? Is 40 beats per minute. Is it regular? Yes, it is regular. What about P waves? P waves are normal, but 2 of 3 has no QRS. PR interval is 0.14 second. QRS duration is normal, so interpretation is AV block of second degree type 2. Occasional P waves are completely blocked. P wave not followed by QRS complex. Conduction is all or nothing. No prolongation of PR interval. Typically block occurs in the bundle of His. Now in this rhythm, rate is 40 beats per minute. Is it regular? Yes, it is regular. What about P waves? There is no relation to QRS. PR interval, none. QRS duration, it is widens. We can see the QRS duration is more than 0.12 second. So interpretation will be third degree AV block. The P waves are completely blocked in the AV junction. QRS complexes originate independently from below the junction. There is complete block of conduction in the AV junction. So the atria and ventricles form impulses independently of each other. Without impulses from the atria, the ventricle's own intrinsic pacemaker kicks in at around 30 to 45 beats per minute. When an impulse originates in a ventricle, conduction through the ventricles will be inefficient and QRS will be wider and bizarre always. Now, ischemic heart disease. It is detectable by changes in ST segment of ECG. To diagnose a myocardial infarction, you need to go beyond looking at a rhythm strip and obtain a 12-lead ECG. This is a rhythm strip and above is 12-lead ECG. The three phases of MI. First is hyperacute phase. Increased amplitude of R wave is found. Slope elevation of ST segment. Tall and wide T waves. Fully evolved phase. Presence of Q wave, curved elevation ST segment and inverted T waves. In chronic stabilized phase, elevated ST segments return to baseline. Even T waves may regain its positivity. Now this is anterior view of heart. The anterior portion of the heart is best viewed using lead V1 to V4. To better understand which part of heart is represented by which lead, you should watch my first video of ECG basics. Putting it all together, do you think this person is having a myocardial infarction? If so, where? Yes, this person is having a fully evolved anterior wall myocardial infarction. Here we can see in V1 and V2 there is a presence of ST elevation. Now, where do you think this person is having a myocardial infarction? Yes, this is inferior wall MI. Note the ST elevation in leads second, third and AVF, which represent the inferior part of the heart. Here you can easily see the ST elevation. What about this? This is anterolateral MI, which involves both anterior wall and lateral wall. We can see in V2 to V4 there is presence of ST elevation and the lateral wall V5 to V6 in lead first and in lead AVL we can find ST elevation. So this is anterolateral MI. This is a quick summary how we should proceed to solve an ECG. First of all, we should calculate the rate, then determine the rhythm, determine QRS axis, calculate all intervals, assess for any hypertrophy, look for evidence of any infarction. Now to finish this module, let's analyze a 12-lead ECG. Read it carefully and we will try to solve this ECG step by step. What is the rate of this ECG? It comes out to be approximate 132. Now next step is to find out the rhythm. It is a regular ECG. Each P wave is followed by QRS complex. So impulse is generated from SA node and presence of tachycardia makes it sinus tachycardia. Next step is to find out the axis. It can be found out by two approaches, either equiphasic or quadrant approach. This is equiphasic approach, and to find out the axis by quadrant approach we can see there is a negative deflection in lead first and a positive deflection in AVF. So it's right axis deviation. These are the different types of interval PR, QRS and QT intervals. PR is equal to 0.12 second, QRS 0.08 second, Qt interval corrected is 0.482 second. Let's find out, is there any evidence of atrial enlargement? No. Next step, to find out any ventricular hypertrophy? Obviously not. Is there presence of any infarction? We can see there is a presence of Q waves in V1 to V6 and in lead first and in lead AVL. Let's find out, is there any ST elevation or depression? Yes, elevation in V2 to V6 and lead first and AVL, and ST depression is in lead second, third and AVF. Are there any T wave changes? No. So the whole summary of this ECG is sinus tachycardia at the rate of 132 beats per minute, right axis deviation, long QT interval, and evidence of ST elevation infarction in anterolateral leads, means V1 to V6 and lead first and AVL, with reciprocal changes, means ST depression in the inferior leads, lead second, third and AVF. This young man suffered an acute myocardial infarction after blunt trauma. An echocardiogram showed anteroseptal akinesia in the left ventricle with severely depressed LV function. Ejection fraction was 28%. An angiogram showed total occlusion in proximal LAD with collaterals from the RCA and LCX. That was all about the basics of ECG. Thank you very much for watching this video. Please like, share and comment below, and do not forget to subscribe my YouTube channel. If you didn't watch ECG basic part 1 video, then please click the link below. Thank you very much.